Hello and welcome to Pharmacovigilance Podcast. Today I have my guest in the studio, Vitali, who is our leading global expert in MedDRA. So, Vitali, can you please introduce yourself?
Thanks, Julia. My name is Vitali Shevts, and I'm medical coding strategy lead at Merck KGaA, Darmstadt, Germany. From background, I'm a physician with focus on internal medicine with more than 25 years of experience in the pharmaceutical industry.
Thank you for your introduction. So we're really happy to have you on board today and you being a part of the ECH MedDRA Steering Committee. So can you explain a little bit more about this committee? How is it working? Are you voting or non-voting members so our listener can understand better your role?
First of all, MedDRA is an ICH topic which will be maintained and distributed by the MSSO, Maintenance and Support Services Organization. And the ICH MedDRA Steering Committee oversees all aspects of MedDRA.
Why it became such a central part of your daily work?
I had strong interest in pharmacology, and that was the reason that I, as a physician, decided to move into the industry. Over time, I explored other areas in the pharmaceutical industry which are relevant for a physician in the industry, like clinical research and medical affairs. But then I discovered medical coding, especially working on med research strategies, and truly fell in love with it. It combines patient safety, clear scientific communication, structured problem solving, all the topics which are crucial for safety, patient safety and benefit. And then as I saw the huge impact of precise terminology and well-designed search strategy on decision-making, I never left this path.
MedDRA is very important for every PV professional. So what do you say? Why MedDRA is so critical?
MedDRA is in many ways, let's say, the language of safety. Every coded term shapes how an event will be grouped, analyzed, and if needed, escalated. Coding isn't just about reporting of a single case. It ensures that events can be accurately retrieved later, for example, in signal detection, risk management, or periodic safety reports. Imagine a library with thousands of books, and all books are placed randomly. If a book is on their own shelf, it becomes almost impossible to find it when you need it. In the same way, if an event is miscoded, or if the search strategy isn't well designed, you may not have a complete or accurate picture of what happened, right?
Yes.
So MedDRA is not just a terminology, it's an architecture of how we understand, manage, and communicate safety data.
I really like how you compare it's the pharmacovigilance language. I really like it. So if we look how people do the coding, what coding mistake you see happen most often?
Challenges which I often see mostly about what is actually recorded versus what is clinically meant.
Mm-hmm.
Common issues include confusion between symptoms and diagnosis, overuse of generic preferred terms, or placing events into their own system organ class.
Okay.
Maybe you think these decisions are small, but they are not trivial because they can also directly affect how signals identified or sometimes even missed. And another major change is also in my perspective, maybe it's really what is very complex topics in MedDRA is the correct coding and interpretation of medication errors and medical device issues.
Okay. Yeah, interesting. If people want to submit the change request, so what is the process and how to do this change request to MedDRA coding?
Change requests should be always medically justified and should always clearly explain why it's so important to submit it and should support also by real-world examples. What is really important, this should address not just the problem that could affect your company, but this change will benefit the wider MedDRA user community.
Have you submit change request yourself?
Yes, I have. Yeah. It's also both for introduction of new terms as well as for SMQs updates.
What happens if there is no SMQ? Can you share a little bit about the customized MedDRA queries?
Great question, Julia. Thank you. First of all, It's important also to apply SMQs in an appropriate way. And if SMQ is available, we should do so, of course, yeah. Sometimes the SMQ is not available. What should we do in those situations? And then we should develop customized MedDRA queries, CMQs, which are internal company-specific grouping of MedDRA terms. They allow us to capture safety concepts that go beyond standard queries or that require fine granularity.
Mm-hmm.
For example, we are using CMQs for data retrieval for adverse event of special interest, events under close monitoring, for risk of signal evaluations, for periodic safety reports, or requests from regulators. It's very fulfilling because you get to help shape the global language of safety.
And can I ask about my favorite part? As you know, I am very passionate about AI. Tell a few words about it, using AI for MedDRA coding. Anything you can say?
From my perspective, artificial intelligence can support consistency, can support routine coding, probably even perform QC checks. AI could also provide suggestions by development of MedDRA queries. But I think artificial intelligence cannot replace medical judgment, at least not today. And it's hard to predict how that will progress in the future. What AI can definitely do is to improve communication and save time, which allow experts to focus on more complex tasks that require clinical expertise.
Yeah, so from my perspective, AI is a tool, and of course, it's a human is responsible for the outcome, but we can use different tools to make our everyday life a little bit simpler or more productive. Can you please share your view on the risk with the use of AI for MedDRA coding?
Sometimes it may lack the understanding of the context. This is also a risk of errors or misinterpretation. And if AI makes incorrect suggestions, or if data are interpreted incorrectly, it would lead to wrong conclusions.
Yeah.
Another risk, I would say, is over-reliance. Teams might start to trust AI too much and so overlook their own critical analysis, as AI can also generate so-called hallucinated mapping. Anyway, AI must always be supervised by someone who understands MedDRA deeply. Otherwise, it could increase errors instead of solving issues.
Yes, I'm totally agree with you. And that's why we have the human oversight, both in the AI Act and also now we have a final version published of the science group on this guidance on AI, and the human oversight is one of the guiding principles for the use of AI. I know you recently been in Singapore for the MedDRA meeting. What was in the agenda of the meeting?
MedDRA Steering Committee meets twice per year together with ICH Management Committee, also with ICH Assembly. Their location will be rotated between Asia, Europe, and Americas. This time it was Singapore. We have full day meetings with a lot of decisions which are really relevant for the MedDRA world.
So what do you think about the future of safety terminology? Will it stay the same? Do you see any changes? What are the trends?
I think what we will have is artificial intelligence, of course, in the future. And thanks to the new tools, we will have the opportunity to spot important threats faster and also see connections more clearly. And thanks to AI, to save time on routine, time-consuming activities, which will allow us to focus on more complex topics and make decisions that truly benefit patients. Therefore, I'm really excited about future where work and patient safety can help prevent harm even before it happens.
Lastly, if you can give one piece of advice for our PV professionals, what would it be?
Please treat coding with passion, not as a routine step. MedDRA doesn't just store information, it shapes the stories that help protect patient safety.
Thank you very much for being my guest in the studio, share your expertise and providing also your insight in the coding strategy and providing this level of clarity. And for everyone who is listening, stay curious, stay safe, and keep using MedDRA for your strategic work. Thank you, and until next time.
Thank you so much.